and we will see to it that all your questions are answered back to your satisfaction. Now we start with today's topic, and today's topic is pancreatic exocrine insufficiency. Okay, this is looks like a very superficial topic, but when I wanted to prepare for it, I found that there is immense amount of literature. Not only there is immense amount of literature, it was very interesting and a challenging topic. So let us start from basics. See, the pancreas produces pancreatic juice, which helps in digestion of carbohydrates, proteins, and fats. When we start eating, there is cephalic and gastric phases of stimulation. Okay, we all know that even smell of food can start the gastric phase of digestive juice secretion. But for pancreas, the most important stimulus comes when the chyme starts leaving the stomach and when it enters the duodenum. So fatty acids, amino acids, and gastric acid, which enters the duodenum, is the most potent stimulator of exocrine pancreatic secretion. This stimulation leads to secretion of two enzymes from duodenal and proximal intestinal mucosa, predominantly duodenal mucosa. These are cholecystokinin, which stimulates the secretion of enzymes like lipase, proteases, and amylase from acinar cells, and the other enzyme which is secreted is called secretin, which stimulates water and bicarbonate secretion from ductal cells. So this is the basic physiology we all must know. And you will see the importance of knowing this basic physiology in coming slide. So what is pancreatic exocrine insufficiency? Definitely, there is some kind of suboptimal production of pancreatic exocrine secretion, but it is defined as a reduction in pancreatic enzyme activity in the intestinal lumen to a level which is below the threshold required to maintain normal digestion. In other words, if you decrease the pancreatic exocrine secretion to 50%, you may not call it exocrine insufficiency. There is decrease in secretion, but the digestion is not affected. Digestion is affected only when lipase activity is reduced by almost 80 to 90%. So pancreatic exocrine insufficiency may not manifest clinically till you have knocked out 90% of lipase. All chronic pancreatitis patients or all pancreatic diseases may not result in pancreatic exocrine insufficiency unless they are quite advanced. Now, it is not only pancreas, but there can be problems in stimulation of these pancreatic enzymes. There can be problems in mixing of chyme and pancreatic enzymes. There can be problems in pH. There can be problems in small intestinal bacterial overgrowth, which can affect the performance of pancreatic exocrine enzymes in the duodenum, thereby leading to maldigestion. So pancreatic exocrine insufficiency can also be because of various extrapancreatic factors. So what are the causes of PEI? I will call now pancreatic exocrine insufficiency as PEI. PEI can occur because of diseases of pancreas like chronic pancreatitis, cystic fibrosis. Cystic fibrosis is hardly seen in our population, and acute post-necrotizing pancreatitis. This is a very common situation which we encounter in our hospital. Obstruction of the pancreatic ductal system by a tumor or a stricture can also lead to blockage of secretion of pancreatic enzymes, leading to PEI. If the duodenal mucosa is involved because of celiac disease or Crohn's disease, obviously the secretin and cholecystokinin are not going to be released and produced. So there is reduced stimulatory capacity. If pancreatic enzymes are inactivated in the duodenum because of very low pH, as is seen in Zollinger-Ellison syndrome, because there is too much of acid, again, that stimulus is removed. And of course, in post-operative states, there is impaired mixing of ingested food or delayed emptying of the stomach, leading to delayed emptying of chyme and or delayed release of pancreatic juices or deficient bile salts. All these lead to pancreatic exocrine insufficiency. So you must have seen actually that we always talk of lipase, 10,000 units, 25,000 units. We never talk of proteases and amylases, right? Why? Why? Because lipase is the determining factor that causes important symptoms and clinical complications in PEI. See, lipase is the most unstable enzyme out of amylase and protease and lipase bunch. If you look at proteases, if you look at amylases, a lot of proteases you will find in stool, but you will not find lipase in the stool because it is readily destroyed in the intestinal lumen. So, and the destruction of lipase is even more rapid when the pH is below 4. So, that is why we talk of lipase when we talk of PEI. Amylase and proteases are also produced by gastric mucosa in large amounts. So therefore, if there is deficiency in pancreatic juice, at least these gastric amylase and proteases take care of that deficiency, but there is no lipase produced in significant amount by any organ other than pancreas. So who are at risk for EPI? Now we are talking about EPI, but we hardly see EPI being talked about in our ward rounds or among the diagnosis in our patients. Cystic fibrosis, not seen in our country. Almost 90% of patients have PEI. Pancreatic cancer, 50 to 65% have PEI, although the lifespan of these patients is not much. Untreated celiac disease, almost 11 to 56%. Chronic pancreatitis, 30 to 40%, and in severe cases, almost 80 to 90%. Inflammatory bowel disease like Crohn's disease affecting proximal bowel, 30%. And one of the most important ones, which we will talk about in coming slides, is diabetes. Almost 30 to 50% of diabetic patients are being shown to have PEI. What are the consequences of PEI? Particularly when we don't diagnose PEI very actively, we can have the consequences of malabsorption of fat-soluble vitamins because of fat maldigestion and malabsorption. And these are vitamin A, D, E, and K. A can produce xerophthalmia, night blindness. D can produce osteomalacia, hypocalcemia, fractures in the elderly. Vitamin E can produce neuropathy, hemolytic anemia, and vitamin K, we all know, leads to coagulopathy. Fat malabsorption or protein malabsorption can cause weight loss, edema, and generalized malnutrition, especially weight loss. How do we diagnose PEI? See, PEI is what we see in our amongst our patients when they present with steatorrhea, presence of oil in stools. Presence of oil in stools is diagnostic. You don't need to do any test. In fact, if you have a background of symptoms and you have a background of a disease which can result in PEI, there is no need to conduct any test. So symptoms in patients are typically foul smelling, loose stools, weight loss, muscle wasting, and flatulence. There is no test required with a clear clinical picture of PEI. However, if you give pancreatic enzyme replacement therapy, and you find improvement, this is also a sign suggestive of your underlying PEI. But the literature says relying only on symptoms may lead to both over as well as underdiagnosis of PEI, because diarrhea, weight loss, flatulence may be due to conditions other than PEI. These are such common symptoms, and PEI can also be present in absence of overt steatorrhea. So, but you see, in most of the situations which we come across, our patients have advanced disease, whether it is chronic pancreatitis or our patients have severe acute necrotizing pancreatitis, or after Whipple's operation, or gastrojejunal partial gastrectomy, etc. All these patients have very advanced symptoms to suggest PEI, and we don't need any test. Okay, but if we need any test, particularly, we should all know what are the tests available. See, the gold standard is still 72 hours fecal fat elimination in the stool. Now, this test, when we were doing DM, there was a small room in GB Pant Hospital for this particular test. And by the time we spent 6 months there, that was wrapped up for good reasons. The patient has to take 100 gram of fat for 5 days, and he has to collect his all fecal matter for third, fourth, and fifth day. It is very cumbersome. It is cumbersome for the patient as well as for the lab. So, and if the fat content of the fecal matter is more than 7 grams per day, it means this is fat malabsorption. But now this is no longer conducted, but it's still in papers, it remains the gold standard. So what is conducted is there are a number of tests. Sudan is telling, you must have seen some reports, especially from Last Lab. It is not being again done in many labs and many hospitals which refuse to do this test. But the most important test is fecal elastase 1. Okay, so this is actually a combination of proteases. This is not a fat metabolizing enzyme. Elastase is basically a protein digesting enzyme, and it's a combination of some chymotrypsins and elastases. And the beauty of this is that it is not affected by therapy. So even if your patient is on uh, pancreatic enzyme replacement therapy, the, the results of this test are not altered. But unfortunately, it has very low sensitivity, especially in the mild variety of PEI. So it is good to screen, but it is the sensitivity is very poor in early cases of chronic pancreatitis or mild PEI. The other problem is that it cannot be used for monitoring. So don't expect that when you have given PERT or exocrine replacement therapy to your patients, then you can monitor it by measuring fecal elastase next time. Fecal elastase will not be changed. Why? Because see, the PERT which you are giving is bovine PERT. Bovine lipase and elastase. And what you are measuring is actually a human elastase. So that is why it cannot be used for monitoring, and it is not affected by therapy. Now, what is the importance of nutritional markers in diagnosis? We know sometimes patients' hemoglobin is low, albumin is low, total cholesterol is low, fat soluble vitamins, all of them are low, calcium, zinc, and selenium are low. So when these nutritional markers are low, then we presume that these are because of protein pancreatic enzyme insufficiency. So the other way of saying it, that a normal panel of serum nutritional markers can exclude PEI with a high negative predictive value. I will give you one example. For example, a patient with upper abdominal pain suspected to have early chronic pancreatitis, comes to you with uh, loose motions for last 2 months, and then you do his all nutritional markers and you find them all normal, the inference would be that this diarrhea or weight loss is not because of PEI. Go and look for some other cause. So now we come to specific conditions. Chronic pancreatitis and pancreatic exocrine insufficiency. PEI is found in from 22% to 94% of patients of chronic pancreatitis. All depends when you have been able to diagnose the patient, how long the patient is suffering with chronic pancreatitis. Obviously, in early chronic pancreatitis, the PEI prevalence would be low. With advanced diseases, it is high. So if your patient has pancreatic calcifications, if your patient has a dilated duct, and the patient is losing weight, patient has some amount of diarrhea or flatulence, this is PEI. If you find uh, imaging evidence of advanced chronic pancreatitis, these symptoms are bound to be due to PEI. The rate of PEI in patient with CP is therefore dependent upon the severity of disease and the length of time since diagnosis. Now, what is interesting is that even pancreatic cancer patients have PEI, and we have already spoken that pancreatic cancer can obstruct the ducts, preventing the pancreatic secretion entering the duodenum, or there has been surgery for pancreatic carcinoma. In both situations, these patients have PEI. In fact, the prevalence of PEI with pancreatic cancer is 80% to 90%. And uh, these patients, although they have so much of loss of appetite, still 40 to 50% of them complain of weight loss, flatulence, loose motions, and of course, loss of appetite. And the literature suggests pancreatic enzyme supplementation should be considered. It should not only be considered, but it has been shown to help these patients in overcoming these symptoms in remaining part of their life. So this is an article published in 2018, 2 years back, which even went on to suggest that there is improvement in survival in patients with unresectable pancreatic cancer if they are treated with pancreatic enzymes. Okay, so this is the only article, and apart from chronic pancreatitis, whatever I am suggesting in coming slides, there is no mention. Uh, I mean, there are not too much of information. There are articles here and there. So these are not the part of guidelines, but these are stray articles on this subject. lot of lot of us do not know that smoking also is a predisposing factor for chronic pancreatitis, and in literature, in certain papers, tobacco exposure has been shown to be a stronger predisposing factor even in comparison to alcohol. So in this particular study, what they found, that patients who did not have any evidence of pancreatitis or any other pancreatic disease, but they were smoking, they had clear-cut evidence of pancreatic insufficiency in 30% to 40%. So this is an eye-opening observation that simple smoking can lead to pancreatic insufficiency, because uh, tobacco is supposed to lead to pancreatic injury over a period of time. Now, acute necrotizing pancreatitis, obvious, when there is necrosis, there is a shutdown of enzyme preparation, and when we start refeeding, these patients suffer from maldigestion and PEI. 25% of all patients with acute pancreatitis develop exocrine insufficiency during follow-up, depending upon the extent of pancreatic necrosis. It is seen more commonly with alcoholic acute pancreatitis. Pancreatic exocrine insufficiency may develop even after mild acute pancreatitis, but obviously it is more frequent in severe, and with passage of time, the PEI may improve as there is pancreatic regeneration. So in this particular systematic review and meta-analysis published 3 years back, it was agreed and they concluded that EPI should be tested for all inpatients with acute pancreatitis before discharge from index admission, irrespective of predicted severity. So these are only conclusions of this particular meta-analysis, and it is not a part of any guideline. Pancreatic enzyme replacement therapy may be considered for patients with persistent EPI. So you do fecal elastase, and if it is less than 100 to 200 microgram per gram of feces, then you can benefit the patient by giving the patient pancreatic enzyme supplementation. Retesting for EPI should be done at 3 months after discharge in all patients. And if you think that there is no EPI after 3 months, you can take this therapy off or continue it for longer time. Yet another paper in 2016 suggested that pancreatic exocrine insufficiency occurs in critically ill adult patients admitted to ICU. And actually, these papers, although they may be initial information, but they are opening a vast amount of research area uh, uh, for, uh, for researchers. So, you know, that patients with critical illness often suffer from pancreatic injury due to non-specific reasons other than pancreatic disease. Just like we see a lot of patients having non-specific elevation of transaminases because of some presumed injury to liver because of sepsis or because of medication. Similarly, there is pancreatic injury, which is still unknown to us in critically ill patients. And there may be a suggestion that critically ill patients who continue to lose weight despite parenteral nutrition, despite enteral nutrition, you have put a rice tube, you are giving enteral nutrition, you are giving parenteral nutrition, patient is still losing weight, try pancreatic exocrine enzyme replacement in these patients, they will improve. This is the observation of this paper. So now the last disease which I want to discuss is diabetes. We all know diabetes is on the rise, and India is going to become, I think, world capital of diabetes. Now, what is actually revealing is that there is some degree of biochemical PEI in up to 50% of people with type 1 and type 2 diabetes. So this is a huge number, although the PEI may not be clinically manifest. And it is important to diagnose and treat PEI because the symptoms in diabetes are very similar. If a diabetes has diabetic diarrhea, autonomic neuropathy, weight loss, this can be because of so many other reasons. But we should not miss PEI in diabetes. We should consider it as one of the possibilities for weight loss, diarrhea, flatulence, and GI symptoms. And if needed, we should get fecal elastase done in patients with diabetes. Generally, the pancreatic diabetes is type 3C diabetes, and according to WHO and International American Diabetes Association, type 3C is seen in about 10% of all diabetics. But the type 3C we understand is because of pancreatic exocrine deficiency producing pancreatic endocrine injury. The etiology, however, in type 1 and type 2 diabetes is not the exocrine injury leading to endocrine injury, but it may be different, and it includes diabetic neuropathy, lack of insulin as a trophic factor for exocrine tissue, dysregulation due to changes in the secretion, and or action of other islet hormones, especially glucagon and somatostatin. And of course, autoimmunity against endocrine and exocrine organs. So the reasons for PEI differ in type 1, type 2 diabetes as compared to type 3C diabetes, which is pancreatic diabetes. So again, I think we can leave this. We have already discussed that the symptoms attributable to PEI in diabetics can also be because of side effects of medication, particularly metformin. We all know 10% of patients on metformin can have diarrhea, and similarly, GLP receptor agonist can have delayed gastric emptying, nausea, and bloating. Now, what is outcome of knowing all this is certain, heartening and welcome that if you treat your patient with pancreatic enzyme supplementation, you treat your diabetic patient with PERT, then the glycemic control becomes smoother. The diabetes uh, gets better faster. Again, this is a paper and this is not a part of guideline. From a practical perspective, patient's glycemic response and blood glucose level should be checked frequently during treatment. If you give these enzymes to a diabetic, please keep on checking blood glucose levels, as there may be a need for reduction of oral hypoglycemics or insulin because of improvement in diabetes. So we now come to the final part of our presentation, and that is treatment of pancreatic exocrine insufficiency. We all know that there are enzymes, pancreatic enzyme supplementation are available in the market, uh, but I think let us discuss some other aspects of treatment of PEI. Lifestyle modifications, we don't probably bother in our busy practice, and that is avoidance of fatty food, low fat diet. But then there is a caveat here. You see, most of our patients have low appetite, they are taking low fat diet. Once they resume taking normal diet, they have more steatoria because they are taking now normal amount of fat. So don't be scared if the symptoms worsen for some time. You have to give more enzymes to these patients. But please insist that the patient takes a normal diet, normal fat, only then he will be able to replenish fat soluble vitamins in the system. Of course, alcohol should be totally banned, smoking should be totally discouraged, and patients should consume a well-balanced diet. Vitamin supplementation, primarily the fat-soluble vitamins A, D, EK, you can, all of them can be given in parenteral form, 3 monthly, 6 monthly, or even yearly. Pancreatic enzyme replacement therapy is the main therapeutic mainstay of treatment of PEI, and we will be discussing the enzyme therapy in next few slides. Now, how do we monitor and what are our endpoints? We have to correct all nutritional deficiencies, and we also have to take care of the causative disease whenever possible. For example, if it is autoimmune pancreatitis, we can give steroids. If it is a stricture in pancreatic duct, we can put a stent, etc., etc. So, few words about enzymes. You see, the typical indication for initiating PERT are weight loss, diarrhea, and steatoria. So this is a classical statement as of now, but as you have seen that PEI exists in many other diseases apart from pancreatic diseases, and PEI may be responsible for symptoms, and PEI may also be helpful in management of certain diseases like diabetes. So the indications of PEI in near future may be much more diverse than we think today. In literature, recently literature review, this was in 2018, and it has established that enzyme therapy is effective against and pancreatic insufficiency, and it leads to improvement in malnutrition. It improves the nutritional status of a patient with chronic pancreatitis. Um, if you talk of investigation, the investigators also establish that PERT associated improvement in the coefficient of fat absorption as well as in the serum nutritional parameters, GI symptoms, and quality of life. So there is all-round improvement not only in nutritional status but also in symptoms, quality of life, and investigations. So these pancreatic enzyme products are available by different names. We have very famous Creon, we have Penlipase, we have other and other companies also throwing up their products. But the basic thing is that we have to see the lipase content of the uh, preparation. Pancreatic enzyme products are a combination of porcine-derived amylases, lipases, and proteases. So this is a donation from a pig uh, pancreas that we are using. Most of the products are enteric coated and do not require PPIs. So why they are enteric coated? Because there are that we don't want the pancreatic enzymes to be released in the stomach. We want them to be released in duodenum, where the chyme enters and natural pancreatic enzyme also enters. And enteric coating prevents degradation of these enzymes in the stomach. Enteric coating opens up at the pH more than 4, which is found in the duodenal lumen. Now, PEPs are not interchangeable. So, for example, if we are giving one tablet or one capsule to a particular patient from one company, and then the patient changes to a capsule provided by another company, this is not interchangeable. We have to observe our patient for at least a month to assure that a patient is taking an optimum dose. In other words, 2 capsules of one company are not equivalent to 2 capsules of another company because of various issues with bioavailability. What is the dose of enzymes? We are all used to prescribing 10,000 international units of lipase or 25,000 or 50,000. And we are also bothered about the cost. But if you go by literature, that PERT dose is based on content of lipase. The pancreatic lipase replacement dose should be adjusted on basis of 3 factors. One, body weight. Patient may be cachexic, he may require smaller dose. Patient may be overweight, he will require higher dose. Clinical symptoms. If patient has absolute steatorrhea, is passing his oil in the stool, obviously we need to start with a higher dose and stool fat content. If your fecal elastase shows a very severe deficiency, less than 15 or 20 nanograms, then you have severe steatorrhea and you can start with a much higher dose. The latest guidelines, particularly Australasian guideline, suggest that you should start with 25,000 units with each meal. So they have written 10,000 units have absolutely no meaning. Start with 25,000. If your patient does not improve over a period of 2 to 3 weeks, take it to 50,000. So 25,000 with each meal, and generally all these patients keep on having snacks. So that is also very important, that you should add pancreatic enzymes with snacks. So half the dose with snacks, 25,000 with major meal, and about 10,000 with each snack. Several days should be allowed between dose adjustment, at least 2 to 3 weeks before you increase the dose. And this I have already told you about meals and snacks. Now, there are sometimes you encounter small children and kids who have pancreatic insufficiencies. The initial oral lipase dose is 500 units per kg per meal. Now, are there any dangers of giving high doses? You see, you should never exceed 10,000 units per kg per day or 4,000 units per gram of fat daily in adults. Okay, so the the problem is that the larger doses can produce colonic fibrosing colopathy or colonic strictures, especially in children. This side effect has not been seen in adults, has not been described in adults. It has been described only in few children, particularly with cystic fibrosis, who require very huge doses of enzyme replacement. And these enzymes are extremely safe. They are devoid of almost any side effect. And this colonic stricture was also attributed to the enteric coating rather than the enzymes themselves. So, colleagues, ladies and gentlemen, I want to summarize what we have learned so far, that PEI is a common problem, but we seem to ignore it in our day-to-day practice. It is far more common than obvious. PERT is an effective therapy. It has been shown unequivocally in literature and in experience, and PERT should be utilized as early as possible to prevent vitamin-associated uh, um, problems. PERT may be helpful in many situations other than simple pancreatic parenchymal diseases. And I think in time to come, in next 10 years, we will see extensive use of PERT, especially in people who have diabetes and severe PEI. Thank you very much. And I'm open to questions. Thank you for your patient listening. Any questions, comments? Yeah.
Dr. Lauti, I'm
Good
Dr.
evening, sir.
Bachchan here.
Thank you for joining.
Dr. Lauti,
Yeah.
good evening. Wonderful presentation for you, sir. Uh, I want to ask you certain questions
Yeah.
regarding PERT therapy in acute pancreatitis. You give recommendation for acute edematous, or we have necrotizing pancreatitis when they are being discharged from the hospital, and also those patients who are associated with those who are having diabetes along with pancreatitis, the recommended doses and PERT therapy in general.
So what I said after reading from the literature,
Yeah,
one that we are no longer doing this practice in general.
in general.
In general, we don't think of providing PERT to our patient at the time of discharge,
Yes.
but there are recommendations, not as a part of guidelines still, but there are recommendations from the literature that you should test your patients for PEI. Now, if there is a patient with acute edematous pancreatitis who has virtually no symptoms, is pain-free, has starting eating again, is well built, like it happens in acute alcoholic pancreatitis,
Yes.
then you can discharge this patient without bothering for PEI or PERT, because we know that patient has resumed eating. On the other hand, there is a patient with 40 or 50% necrosis who has improved but is not able to take full diet. We know that when the patient will resume full diet, this necrosis will cause PEI. So we can get a fecal elastase done for this patient, or even if fecal elastase is not done, we can supplement his medication with PERT for few weeks till there is recovery. And this recovery has to be monitored clinically and symptom wise.
Symptom wise.
If your patient is gaining weight, if your patient is eating, then you can probably stop PERT after 4 to 6 weeks or 2 to 3 months, whatever.
Thank you. Thank you, sir. Thank you.
Hello.
Yes.
Yes.
Good evening. Good evening, Dr. Lahoti, Dr. Monica this side.
Yeah, Dr. Monica, please.
Very nice and very informative lecture. Used to have these lectures in our DM days only.
Thank you.
Now, something I wanted to ask, because most of the patients of chronic pancreatitis who are getting these enzyme therapies,
Yes.
they clinically or subclinically are for PEA.
Yes.
Clinically or subclinically, they are not tested for insufficiency, and most of them they are getting these preparations for pain only, for, as part of pain therapy. So,
Yes.
what is your comment about that? Because for pain therapy, we don't need.
Yeah. So sorry, there is some
For,
audio interruption, but I have got your question. If I have got your question right, it is, you see, you use the medications or PERT for two reasons. One is pancreatic exocrine insufficiency. The other reason is that you want to treat the pain. Is that right? Is that the question?
most of the patients who are discharged, they are getting these therapies for pain only.
Yes.
Pain,
Yeah.
because they are invariably not tested for PEI. And for pain, we know that we don't need lipase. So many of them, they are getting very high dose of these enzymes, which are having very high lipase level. Although for pain part, we need basically proteases.
I entirely agree with you that when we uh, release or discharge our patients in of acute pancreatitis, we hardly bother about PEI. So that is something which we ought to do now on day-to-day basis. When we want to treat our patient for pain, pain is basically in pancreatitis comes because of three reasons. One is ductal obstruction,
Yeah.
one pancreatic intrapancreatic hypertension. That means there is increased pressures within the pancreatic parenchyma, or there is peripancreatic neural involvement. So, you see, we must give trial of pancreatic enzymes. When we give pancreatic enzyme, because of negative feedback, the pancreatic secretion decreases in the pancreatic parenchyma, and this is supposedly this will bring down the pressures within the parenchyma and decrease pain. So this is the theory, and most important is protease. I agree with you. It is not lipase, protease. But unfortunately, see, we all know that we are uh, measuring the success of pancreatic enzyme replacement therapy in terms of lipase only.
That is a problem, because we
Yeah,
don't have any preparation which is purely of proteases.
yeah.
All the preparations are with higher and higher doses of lipases only, not the proteases, which is the main part which is required for pain part in chronic pancreatitis.
But Dr. Monica, I think in with one stone you are killing two birds. If you are giving it for pain, possibly it is covering PEI, which was not clinically evident to you. So probably even PERT for pain is helping subclinical or clinical PEI also in these patients.
One more issue is there, that most of these patients, they are on PPI, and whatever the preparations we are giving, they are entry coated. So the
Yes,
proteases, they require a basically low pH to act on, which is not there when we are giving these entry coated preparations to the patient with these PPIs. So that is a problem, because we don't have any un uncoated preparations which were there used to be with us previously. We used to have pancreoflat, which was not non-coated preparation, which
yes.
we used to give. But nowadays, all preparations, what I feel, I don't see any preparation which is uncoated.
So I'm sorry, I don't have much knowledge on your last comment that proteases will need a low pH. I do not know anybody else who would like to comment or uh, on this statement. Anybody has knowledge about proteases requiring low pH? Dr. Monica, I think I will like to read and
I will also check up because this we used to read in that our DM days only, because entry coated are not present, non-entry coated preparations are not available. This is sure.
yes,
And we are giving PPI to almost all the patients.
yeah.
So the combination is, let's see. We
No,
will,
generally, it's not recommended to give PPIs. We are actually abusing PPI therapy. We are
but
giving right and
indirectly,
left to everybody,
if
but
you will see the preparation, these all the prescriptions, 99% they will have one PPI, one enzyme, one antioxidant, and low fat diet.
so what is suggested if your patient is not improving on high doses of pancreatic enzymes, there may be some other factors, for example, lack of bicarbonate in pancreatic juices.
Mhm.
Then you add PPI. And it has been shown addition of PPI, with addition of PPI, the patient may start responding to same dose of enzyme therapy.
Yes, yes.
So this is all sort of, you have to monitor clinically.
Very informative lecture, very informative. Thank you.
Sir, there are a few questions on the chat box also.
Yeah.
So they are asking what are the indications of PERT therapy in the absence of steatorrhea and weight loss? If the patient has no steatorrhea or weight loss, then what are the indications?
So all the indication would be, I will say, relative. Okay.
Okay.
If you have lost muscle mass recently, you may not be having steatorrhea. But still the clinician thinks that this muscle loss of muscle mass or sarcopenia is because of malabsorption of protein.
Okay.
But then the PEI PERT will help in these patients with background of pancreatic exocrine insufficiency. It is not in every case of sarcopenia, but in
Okay.
a patient who has chronic pancreatitis losing muscle mass, PERT will help as per
Sir,
the
okay, okay. Sir, Mujumdar sir from Max Special is asking, so what should we ask for the patient? Should we ask him to restrict the fat or we optimize the dosage of enzyme replacement?
Yeah, so this is a very important practical problem. I think we always start with low fat diet, so that if you confront the patient with a high fat diet to begin with, he may have more steatorrhea and he may not be able to control his stools, and he may actually lose interest in your therapy. So you gradually increase the fat and gradually increase the pancreatic enzymes, both. And see, in our practice, we have a limitation. Pancreatic enzymes are very expensive. If you talk about 25,000 units with every meal and 10,000 units with every snack, it almost comes to 200 to 50 rupees or maybe more per day, which is a lot of expense for most of our patients.
Right, right.
Any other question? You said there are some other questions also.
Sir, they are asking in natural history of chronic pancreatitis in our setup or in any setup. Do we get patient with diabetes first or the symptom of pancreatic deficiency, exocrine pancreatic deficiency?
Yeah. So in actually natural history of in Indian scenario where we have what is called as idiopathic chronic pancreatitis, and we also have a syndrome of tropical pancreatitis. The tropical pancreatitis, which was described 30 years earlier by Dr. Narendra Nathan, etc., from Kerala, that where the patient would be a malnourished person with protuberant abdomen, and when X-ray was taken, there was extensive calcification of pancreas. So this was a typical scenario of what was called as tropical pancreatitis, and this was seen in South India only. Although nowadays the composition of pancreatitis has changed. There also, the shape of pancreatitis presentation is almost the same as in North. In North India, we never used to see classical tropical pancreatitis of Kerala, which was described in books. Okay, so your question about natural history of chronic pancreatitis, the exocrine part comes first, and then comes the endocrine part. And this is very characteristic of type 3C diabetes also. In the pathogenesis of type 3C diabetes, you can read that the exocrine injury to pancreas is ultimately leading to endocrine injury. It is affecting the endocrine part and leading to diabetes. So first is exocrine part. Although there may be patients who come to you or who come to your attention because of diabetes. So once they come with diabetes, you start investigating them and you find that they have underlying chronic pancreatitis, which was not ever suspected in the past. So exocrine first, then endocrine.
Then endocrine. Okay.
So Nitin, I just want to add why I told you about tropical pancreatitis of the South.
Okay.
Because by the age of 14 or 16 years, the patients were malnourished and diabetics already. So it was attributed to cassava intake in those areas, which was a staple diet of many poor families in South India, especially Kerala. So the diet or cassava, it was true, then it started hitting their pancreas right from childhood. So in 12 to 14 years, they became diabetic also.
So, and sir, is the PERT is helping in a patient with DM type 2? Means if a patient of chronic pancreatitis is developing diabetes, so how is it helped?
If a patient with chronic pancreatitis developing diabetes.
Yes.
So both,
how?
I mean, let us say a patient with chronic pancreatitis has type 2 diabetes. This is what you want to say?
Yes, sir.
A patient, mother, father were also diabetic, so patient has a genetic component. The pancreas itself does not have very extensive exocrine pancreatic dysfunction, but patient has developed type 2 diabetes. Now, this is what I wanted to emphasize. If your patient is having diarrhea, flatulence, okay, and you have ruled out infection, diabetic autonomic neuropathy, celiac disease, and other possibilities which are seen in patients with diabetes, including IBS, then you should focus on presence of PEI in this particular subset of patients. Get fecal elastase done. If it is low, treat this patient with enzyme supplementation. And if patient improves, this further attests to your right diagnosis that this patient had PEI.
Okay.
But still, it is not a part of any guideline that you should screen all your patients of diabetes for PEI. That's not a part of guideline. Any other question? Okay, so I can also see the questions here.
Yes, sir.
Okay, so Ashish is asking, what is the natural history of chronic pancreatitis in respect of exocrine and endocrine deficiency? Is there
You
any?
already told, yes.
You've already. Is there any significant difference among different causes of chronic pancreatitis? Uh, I won't be able to answer that scientifically. I don't know whether different causes of chronic pancreatitis will behave differently. I'm not sure. As you told, parenteral vitamin supplementation is to be given, so oral vitamin supplementation should not be given. No. I'm saying that to make up for the deficiency, you can, and to make sure that vitamins have reached the body, you give parenteral shots of vitamin A, D, E, and K, right? But all these vitamins can also be given orally when the fat is being absorbed these vitamins will also be absorbed. And you give, to start with, you give parenteral, then you can continue with oral. PPIs should be added with PERT, not in the beginning, but if you think that your PERT is not working with expected doses, you can add PPI. Should we restrict fat or optimize enzyme supplementation? This we have already spoken.
Yes, spoken. Yes, sir.
In absence of obvious signs of steatoria, no weight loss, when we have already
You
spoken.
already answered. Yes.
Enteric coated or non-enteric coated tablets, which you prefer? So most of them are enteric coated. The non-enteric coated are not available most of the time. I would prefer enteric coated, and I will also prefer, the microspheres of 2 millimeter or less. If somebody has some capsule has a big microspheres, they may not empty with chyme into duodenum. So you have to use small microspheres. Why only lipase replaced in PEI and not protease? I have already explained, it is the lipase deficiency which matters most, because proteases can come from gastric mucosa. They can compensate. There is protein malabsorption also, but not as much as lipase, lipid malabsorption. Next question is type 3C diabetes incidence in CP and difference in management compared to type 2 diabetes. All that I know, that type 3C diabetes will certainly require insulin most of the time, and they have more frequent episodes of hypoglycemia as compared to type 2 diabetes. But I think we can ask a diabetologist to speak on this particular aspect in one of our sessions. What mechanisms improve diabetes mellitus by PERT, content of PERT and micronutrient replacement? So there are mechanisms. If you give PERT to a patient of diabetes, then you see various mechanisms which have been explained include gastroparesis, increase in GLP-1 enzymes, and there are three mechanisms involved. I can recall two. One is decreasing the gastric emptying, and second is I think when there is some amount of gastroparesis, the gastric emptying is not fast, then these medication, oral hypoglycemics also are absorbed better. And the second one, which I told you, is increase in GLP-1 agonist elaboration in the mucosa. And the third is that PERT themselves lead to increase in secretion of incretin and incretin-like molecules, which also smoothen the action of insulin. Okay, so, these are few mechanisms described. Content of PERT. Content of PERT, for example, in classical molecule, you have 10,000 lipase, about 800 protease, and amylase is very small. So mainly it is lipase. Micronutrients replacement, yes, definitely. All these patients can have florid manifestations of malnutrition. They can have manganese, selenium, calcium, and all deficiencies, and these need to be replaced. Next question is in patient with CP, which comes early in natural history, that we have
You already told.
discussed. Yes. How robust is literature regarding fecal elastase for diagnosis of PEI? Okay, so this is something very important question. See, fecal elastase is the only test which is available right now to a common general clinician like us. As I told you, 72-hour fecal fat excretion is absolutely not possible. Most of the labs, in fact, It is not being done anywhere in North India. And if it is being done, it must be there because of some research project. But it's still in literature, it is a gold standard. Now, fecal elastase, you require only solid stool, one-time solid stool, which patient can bring in a plastic pouch to the lab. And moreover, you even if you keep this stool at room temperature for 5 days, nothing happens to elastase. It is robust molecule. In next 4 or 5 days, you can do elastase. Okay, and elastase is also not affected by PERT. Even giving enzymes to your patient, you can still get elastase done. So these are the qualities of fecal elastase. The only problem with fecal elastase is that its sensitivity is very poor in early PEI. Uh, that's all. And in early PEI, probably you will not also like to treat your patients with PERT. Do you start enzymes for pain in CP? Yes, we have already spoken.
Yes, you already
How
said.
many percentage of patients presenting with CP without any etiology of CP? What is the mechanism? So this is again a question which is related to chronic pancreatitis, and I can tell you that among chronic pancreatitis, 60 to 70% would be because of alcohol. This is a North Indian figure, and 20 to 30% will be what is called as idiopathic. These patients are non-alcoholic, and among them, there will be a subgroup. If you diagnose further, some people will turn out to have hyperlipidemia. Some people will turn out to have hyperparathyroidism. Okay, so some patients may have pancreas divisum, and some a very minority of them may have autoimmune pancreatitis. So these are other four causes. And if your patient is less than 20 years of age, you should always consider genetic reasons, genetic mutation for before you for your patient with chronic pancreatitis. Now, the next question is what is the natural history of chronic pancreatitis? Uh, what is the
No,
sorry.
you.
You've gone on. What is the natural history
Yes.
of chronic pancreatitis in respect of exo and endocrine deficiency? See, the natural history would be that both these deficiencies will gradually increase with passage of time. Um, but I think I can take up this question in next talk before we start next talk on next Sunday. We can take up such questions which are not fully resolved. Recurrent acute pancreatitis, idiopathic, what shall be the rate of progression to CP? See, generally recurrent acute pancreatitis will not lead to CP. Only rarely you can have scarring in the pancreas, which can lead to ductal strictures, and these ductal strictures then can lead to changes suggestive of chronic pancreatitis. But in most of these situations, I tell you, this is chronic pancreatitis right from the beginning, which has been misdiagnosed as recurrent acute pancreatitis because of exacerbations of acute pancreatitis. So if you have access to endoscopic ultrasound, which can detect chronic pancreatitis than other investigations, you will find that many of your patients whom you are calling as recurrent acute pancreatitis are actually have underlying chronic pancreatitis. Which patient of DM should be screened for PEI? Okay, once again, this we have discussed that patients
Yes.
who have symptoms of flatulence, diarrhea, weight loss, which are still are unexplained by various other diseases which you can think of, like malabsorption, celiac disease, autonomic neuropathy, SIBO, etc. And you have treated all these conditions, but still patient continues to have symptoms and lose weight, you should consider PEI in such patients. For PEI to manifest, 90% exocrine part must be exhausted, but diabetes can be there even if 70% islet is exhausted. So looking at that, isn't it possible diabetes comes ahead of PEI? So you are, I mean, this statement is fine, but in patients who have chronic pancreatitis, typical chronic pancreatitis, it is the exocrine part which is damaged first, and endocrine is still preserved. But so diabetes comes later. Although you are right, it may come, in some patients, it may be apparent earlier than advanced exocrine deficiency. The problem with pancreas is, and interpretation of these studies is difficult because you cannot biopsy pancreas again and again. So pancreas has a problem that histology is not available. Otherwise, if a biopsy was available, you would have had clear picture of natural history, exocrine damage or endocrine reserve, histopathologically also. Normal levels of CA 19.9 in CP without any evidence of cholangitis. So I don't know what is the question. Normal levels of CA 19.9 in chronic pancreatitis without evidence of cholangitis. I think somebody has to frame the question again. I'm not sure what is he asking.
Okay.
Okay. So is there a protocol recommendation for screening for carcinoma pancreas in setting of CP? Yes. In fact, 9% of patients with chronic pancreatitis ultimately go on to develop pancreatic carcinoma. So is Dr. Mazumdar there? Dr. Mazumdar is there or has he left?
So he was there till now, I think.
Okay, okay, doesn't matter. So this question will be answered in next talk before we start the next topic. See the protocol, I do not remember protocol recommendation, but I am very sure 9% of patients with chronic, severe chronic pancreatitis, longest standing pancreatitis will develop carcinoma. So what is the recommendation for screening? Just like we screen HCC, is there any protocol for screening? Let me read and tell you. What is the cutoff for fecal elastase to say PEI? 200. 200 nanograms per gram of fecal fat, feces. 200 nanograms per gram of feces is the cutoff value. If it is less than 200, it means there is PEI. If it is less than 100, moderate PEI, and if it is less than 30, it is severe PEI. Okay. Any preparation containing enzymes and micronutrients, vitamins.
I think he wants to ask you how you supplement all the micronutrients, whether fat soluble vitamins or.
No, he is trying to ask, is there any single preparation which contains enzymes, micronutrients, and vitamins?
Okay.
So again, I'll have to brush up my knowledge because the common ones do not contain micronutrients and the vitamins. Kindly share slides. Yeah, I'm going to share the slides soon after this. Okay.
Okay.
Sure. And okay, so I do not know how many people are there right now. Monica, are you there? Has Monica left? Dr. Monica?
I think she left, sir.
She has
Yeah.
left. So
Yeah.
you see, we require people to.
I'm there, sir. I'm there.
So, Monica, you decide when do you want to speak and on what topic.
Sir, I will let you know by tomorrow or day after.
Sure, because 30th we are having coagulopathy. Okay.
So you want me to talk on hepatic hydrothorax? I can talk on hepatic hydrothorax.
So sure, we can, you just give us some kind of confirmation. So we can amalgamate, we can take 2 or 3 speakers in one sitting on hydrothorax, portopulmonary syndrome or hepatopulmonary syndrome and finish that topic.
Okay. Let me check what all I can make. Hepatic hydrothorax, I took a lecture for my PGs once. I will check up the slides. Okay. Then the second one I will have to see.
Sure. And on 12th of September, we have a session on nutrition. Monica, Dr. Ashwani Setia is going to teach us on refeeding syndrome in particular.
Okay, okay, okay. Very good.
We do not know much about refeeding syndrome. So that would be a long session because we have to cover whole aspects of nutrition, enteral nutrition, parenteral nutrition. Okay,
Okay, okay.
right. Nitin,
Yes, sir.
Nikhil is there.
Yes, yes, sir. He's there.
So let's make it bi-weekly. Let us decide right now. You should present a case at least once in 15 days. Let's begin with this. On Zoom only.
This I wanted
Okay,
to
sir.
say, because these webinars, there are too many webinars nowadays, but the case presentation is not there. These PGs, they have to see that case presentation also. What
Sure.
all is asked in that case presentation. So
So
they can pick up one topic, say ascites, or any topic, IBD or bloody diarrhea or dysphagia.
no, they have
That
to
way we can
present
make a list of cases
it.
which are generally given in DM exam, this
Yeah.
DNB, DM exams.
Sure, sure. So can we meet on Thursday? 9:30? 9 p.m.
9:30 is okay, because 9:30, by 9:30 everything is finished otherwise.
No, I'm just saying that can Nitin or Nikhil, these are our postgraduates, can one of them present a case on Thursday?
Okay, sir.
Okay,
On Thursday.
Nitin, let's make a
Okay, sir.
beginning. Okay.
Okay, sir. Okay, sir.
I think once a month once in 15 days you can present, and once in 15 days Nikhil can present. So we will not be left behind. And we will be able to cover this aspect of your
Our
training.
PGs are there. We have two PGs also with us, so they will also present.
They can also present. Why don't
They-
you ask, Monica, why don't you ask your PGs to speak to us, and you can actively involve them in teaching?
I will let you know. I will tell them to call you.
Okay,
tomorrow.
okay,
So you guide them what all to be done.
okay, sure.
Okay, okay, sir.
Okay, thank you everybody, and
Thank you, sir.
good night. Good night.
Thank you, sir. Good night.